Good afternoon, colleagues, or should I say it's almost evening. So welcome to the College of Public Health Medicine's Pholela Lecture 2025. A special welcome to the members of the College of Public Health Medicine that are in the venue and that are joining online, colleagues from our sister college, the East Central and Southern African College of Public Health Physicians, as well as colleagues from the other constituent colleges of the Colleges of Medicine of South Africa. And I think many of you would be attending the Pholela lecture for the first time. I think let me acknowledge the presence of the leadership of CMSA, Prof Zakotto, President, and the other colleagues in the Presidium. Let me thank the organizing committee of the 70th anniversary CMSA conference for agreeing to host this year's lecture at the conference. And I don't think it has anything to do with the fact that the chair of the conference is a public health medicine specialist, or the CEO. The Pholela lecture is the eponymous lecture of the College of Public Health Medicine, and like all eponymous lectures within CMSA is a formal occasion, and that would explain the gowns. The lecture was named Pholela after the Pholela Health Center in KwaZulu-Natal. For those of you that are not familiar with the Pholela Health Center, it's regarded as the origin of community-oriented primary care. For us in the College of Public Health Medicine, the Pholela lecture symbolizes a standard for health systems responsiveness to the needs of communities that is predicated on a population health perspective. With respect to the regulations for the Pholela lecture, the awardee must be a fellow or associate member of the College of Public Health Medicine or an equivalent specialist body internationally, and that person must be nationally or internationally recognized for their contribution to health systems. I don't think I actually introduced myself at the start. So I'm Professor Sandra Ridley. I am the president of the College of Public Health Medicine. So in terms of our nomination process, for the first time this year, and this is the fourth occasion that we are all holding a Pholela lecture, but for the first time this year we had an open nomination process where members of our college were able to nominate their choice for the awardee. A subcommittee of our college then developed a short list of nominees, which was then submitted to our council to select the awardee. And now to the actual awardee. This year's Pholela lecture will be delivered by Professor Nicholas Crisp, and I think to most of us he needs no introduction. I think most of us know him as the face of national health insurance. But I think what many of us would not know until today is that Nicholas is a public health medicine specialist, and a proud one at that. He completed his M.Med in community health, as the specialty was then known, in 1991 at the University of Pretoria. His work in health systems strengthening spans more than 30 years in South Africa and the rest of the continent. He obviously has a very long CV, so I'll just pick out a few highlights. He was Superintendent General of the Department of Health and Welfare in Limpopo, where he served from 1995 to 1999. Thereafter, he worked as a self-employed consultant on health systems projects in various countries on the continent, including South Africa, Nigeria, Ghana, Lesotho, Botswana, Namibia, and Tanzania, until 2021. Some of the critical projects that he played a key role in South Africa include the establishment of the National Health Laboratory Services, the NHLS, the transfer of medicolegal mortuaries from police to health, and the creation of the Forensic Pathology Services, and the establishment of the South African Health Products Regulatory Authority. In 2021, he came out of semi-retirement and farming to assume the role of Deputy Director General National Health Insurance. I'm not sure if he regrets that or not. And obviously during the COVID-19 pandemic, he led South Africa's COVID-19 vaccine program. Amongst his accolades, Nicholas was awarded the Public Health Association of South Africa's Lifetime Achievement Award in 2023. The awarding of the College of Public Health Medicine's Pholela Lecture 2025 to him means, in my view, he has received the two highest honors that a public health medicine specialist in South Africa can receive. As I said, he's a proud member of the College of Public Health Medicine and a great advocate for our specialty, which I think is a recognition from his own experience of the critical role that public health medicine specialists can play in health system strengthening. As head of the NHI branch, he has for the first time within the National Department of Health appointed public health medicine specialists in designated specialist roles. While many of us might have differing views with him from time to time, I don't think any of us doubt Nicholas's passion, commitment, and contribution to South Africa's health system. I think Nicholas epitomizes the kind of awardee we had in mind when we conceptualized the Pholela Lecture. Ladies and gentlemen, it's my great honor to call up Professor Nicholas Crisp to deliver the Pholela Lecture 2025.
Well, good afternoon, ladies and gentlemen. Thanks very much, Sayendra, for that introduction. It's almost as long as what I'm going to speak. And thank you very much to the Colleges of Medicine, and particular to my college and the colleagues in the college for the nomination and for awarding me this very prestigious lecture. I hope I will do it justice today, and I will do my best to stick to the topic and not stray into everything that's related to my day job. But unfortunately, I do need to talk a little bit about that, because that's really, health systems reform has been my bread and butter for the past 40 years, actually. So, and I also want to say that I need to blame Eric Buch that I'm a member of this college, because in 1986, Eric convinced me to give up my future career as an orthopedic surgeon. And instead of dealing with post-polio surgery, which is what my passion was at that time, he persuaded me that it was far better to deal with immunization programs. So if you have a problem with me, deal with Eric. So let's get to the lecture, and thank you very much for your ears. I'm going to talk about health systems reform in South Africa, and I will spend a bit of time talking about the role of specialists. So I'm going to start off just setting the context about why we believe there's a need to reform, and we'll deal with what's the problem and what these massive systemic health reforms are that we believe is necessary. So in the actual reforms, I'll talk about the NHI, obviously. What is it aiming to achieve, and why do we think that it is the solution that we should be striving for? And then we'll get to the role of medical specialists in general, and I'll end off talking about the role that my own college and the members of my own college could and should be playing in health systems reform and running health systems. So I think we all know by now that we had some delays with the pandemic, the COVID pandemic. We've been working on the national health insurance since the dawn of democracy, one way or another. And there have been different approaches that have been mooted. But for the past 20 years, we've had a green paper and a white paper and another white paper. And I watched from afar while I was working in Nigeria. I was working on the NHI there and in Ghana and on a number of other projects in other countries. And I was watching from afar as it was evolving. That process culminated when the bill was tabled in Parliament, passed by the National Assembly, passed by the National Council of Provinces, and was signed into law on the 15th of May, more than a year ago, in 15th of May 2024. So we've reached a major milestone that there's now a law. It's an act of Parliament. Not everybody's happy with it, so it's contested in courts, because it is so fundamental and it makes such massive changes to the way that our health system functions at the moment. And it's no surprise that we should expect some of the pushbacks. I'll talk a little bit about the two phases when we get there. So before we get into what these reforms are about and why they might be contentious, let's first look at what are we aiming to fix. So in this slide, we can see countries across the world. This is the average expenditure on GDP across the world, spending on healthcare. And you'll see that the global average is now sitting quite close to 11% of countries' GDP. Now, when you look at averages like this, those of us who spend our lives looking at data and statistics, we all know that this masks a whole lot of inequities and differences from one place in the world to another. But generally, we have seen an increase from round about 8.5% as the global average to 11% in the last 15 years. So where does South Africa sit in this? You can't read the labels of the countries here, but you can go to the WHO reference and you'll be able to see this data, and it's being updated by countries as we go. Not every country's data is at the same point in time, but they do tell you in the data set which year the latest data is for. And of course, people measure using slightly different methodologies. This is the World Bank's report from the 7th of April 2023 that I've used here. And you'll see that South Africa spends, as a percentage of our GDP, a high proportion compared with many countries. We are nowhere near those few on the left-hand side of the graph, like the United States and a couple of other smaller states, that's spending 10, 11, 12, 15, 20, up to 22% of their GDP on healthcare. The United States is differently reported by different sources at between 18 and 22% of their GDP. That equates to more than 40% of the world's spending on healthcare. So it's very different from one place to the other. And of course, the sizes of our economies are different as well. So who do you compare with and what are you looking at? So what we tend to do is we look at our own trend over time. Are we spending more? Are we spending within our means? Are we getting an outcome for that input that justifies the spending that we're incurring? And we're going to drill further and further down into where do we spend this money and who is incurring that cost. So you'll see we're currently sitting at about 8.5% of GDP. So during COVID is the highest that we've ever spent. Other departments in government had to contribute to the health department for the COVID response, but we are now sitting at around about 8.5%. And it's come up from 7% 15 years ago, using the same set of data. So now we start going into where's this money spent? The data for this slide comes from National Treasury, and it adds up all spending in the public and private sector and the total. The outlier there in 2021 is the COVID spending, and the gray bars that you'll see are the total spend in the private sector, and the orange bar is the total spend in the public sector. So we are starting to see a decrease in spending in both public and private sector as a percentage of GDP. That's one way to measure how we spend. But we also need to look at it in rand terms. So our rand is not buying as much as it used to. We have a slow, if at all, growing GDP. So it's not always easy to say, what are we actually getting as value? The actual money, the purchasing power parity against other countries and against our previous years. But what you see in this slide is over the last 15 years, the nominal rand growth in the spending on healthcare, the top line, is the private sector, which is basically a straight line. You just keep adding the price and you keep adding to the amounts that people must pay for their voluntary health insurance, whatever form that takes, and you just keep it in a straight line to cover the costs. And the number of people who benefit has not materially changed. The population has grown, so the percentage of the population that is covered by these voluntary health insurance packages is reducing every year. So we're sitting at 9.1 million people now, which is a lower percentage than 9.1 million was 3 years ago when the population was substantially smaller. But look at the second line. That's the public spend. And it is reducing. We're trying very hard to pick it up now, and it was sort of at its highest during COVID. And then after COVID, there was this reaction, your patients aren't coming anymore, we don't need to give you so much money. So the public spend, the allocations that were made reduced, and we're fighting back on that. So the next question is, so what does government spend on healthcare? That portion, that 49% of the total spend that is spent in the public sector, what is that as a percentage of the total government spend? And we know the Lusaka Agreement, we are all aiming for 15%, and lo and behold, we're sitting on 15% as South Africa. Many other countries, I worked in Nigeria when it was sitting at under 3%. The whole time, 16 years I worked there, was under 3% of their government spend was spent in healthcare. And we are sitting at 15%. So what do we do with this money and where is it being spent? Well, the next thing is to work out and to see for ourselves, what's the value of that money? What can it buy? And what you're seeing in this slide is the declining allocation in real terms of the money that we have allocated and have accessible to us to spend. And you'll see the nominal value increasing and then having this hiccup post-COVID. And that hiccup translates to a decrease in real spend in healthcare. Now we have a dual system, and I'm going to go into each of them and show where the inequities are. So I've already shown the inequity between the public and the private sector. 9.1 million people consuming 51% of the total spend, and the other 53 million or 52 million, depending on whose figures we are quoting, spending the remaining 49% of the budget. And of course, it's not an equal comparison because the public sector is paying for malaria control programs, port health services, forensic pathology services, and a whole range of other public health programs, HIV programs, immunization programs, with a disproportionate share of the responsibility, sometimes 100% of that responsibility for all of us. So it's not an entirely fair comparison, but let's just accept that that is what is spent in the sectors. If you look at what is spent in the private financing space, just the medical schemes now, and we know there's a growing proportion of spending that's taking place as out-of-pocket spending and as health insurance that's not governed by the medical, well, it's governed by the medical scheme, but as an exemption. We call them demarcation products. These things where you buy your coffin and your funeral at the same time as you buy your hospital cover. This does not include those. This data, which shows 2023 data, shows us where the total benefit spend was and the risk benefits plus the savings benefits, so those sort of gap cover things. And you'll see that we are spending a huge amount of money on hospitals and specialist services. And I'm going to end with talking about our role as specialists. Not only the clinical specialists, but those of us who work in the health systems as well. We're spending a lot of money in this space, and in the private sector, very little in primary healthcare. You can see the spending on GPs and other primary healthcare services. You almost can't see it in this graph. So in rand terms, what this translates to is a growth in spending in the private sector in the top half of these two graphs. That shows that we are currently spending 28,000, just over 28,000, 28,000 or 26,700 up to 28,000 this year per capita on paying for healthcare in the private sector, total spend. The public sector has finally passed 5,200 rand per capita already with the additional spending that goes into all these other programs, as I indicated. That's a five-fold more spend in the private sector than in the public sector. So it's no surprise that you're going to get different outcomes and different qualities of service. The administrative cost of managing the portion of the system that looks after the 9.1 million people who have voluntary health insurance is huge. And it's a design problem. So whether, sometimes it's perceived that we in the department and I in my personal capacity am attacking a medical scheme. We're not. It's a design problem. We have 71 medical schemes. We used to have 200. We now have 71. Those 71 medical schemes have 311 different options. So I guess that every South African in this room has got some form of medical scheme. 35% of us will have hospital cover. 25% will have comprehensive, and the rest in between will be told you can't go there, you can only go here because that's your designated service provider, and there are limitations on where you can access that healthcare. These schemes have 833 trustees in 2022. I don't know the actual number today. They were paid 104 million rand. The trustees who come to the trustee meetings, not the administrators. Administrators, what are called principal officers, are paid anything up to 9 million rand a year to look after 500,000, 1 million lives. And the biggest schemes are not the ones with the highest paid principal officers. The collective principal officers of these 71 schemes were paid 140 million rand in that same year. This is expensive. They have to have duplicate digital systems to sift out whether you're pre-authorized, whether you qualify, to deal with their fraud management and so on. And the fraud that was reported, and again reported in the Sunday Times this week, is between 28 and 30 billion rand a year. I want to repeat that. Fraud, waste, and abuse is 28 to 30 billion rand a year in the private sector, looking after 9.1 million people. That is 6 times higher than the Auditor General reported as unauthorized and illegal expenditure in all 10 health departments of the country. And yet all the flack is on the public sector because we waste money and yes, there's fraud. There's corruption in the systems, but it's everywhere. So this constitutes waste, and all that waste is inefficiency that does not go to patient care. So we have argued repeatedly that up to 50%, in fact, my figure shows more than 50%, of all spending in the private sector adds no value whatsoever to patient care. 1.2 billion rand a year on marketing. We spent 28 million rand on a communication campaign and we're slated for it in Parliament. It's just, you know, the orders of magnitude of the dichotomy between the two systems is just unbelievable. Okay, so let's look at the public service now. I pointed figures at the fraud, waste, and abuse and the challenges within the private sector. Let's look at what happens in the public sector. We're spending more and more money in primary health care. This is good. We want to prevent things from happening that shouldn't happen. Hypertension, diabetes, and a whole range of infectious diseases that we can immunize against, and other interventions. So that's not necessarily a bad thing. But look at that purple line in the middle, which is the district hospitals, the smaller hospitals, the ones that everybody goes through for everyday hospital care. We're spending less and less on those hospitals. Largely because the expensive high-end care, and we're going to come to specialists at the end of the talk, is costing more. Do we get value for that money? Is this the correct way to be allocating our resources, or should we be spending more on district hospitals and training the medical officers who work in those district hospitals to do more and supervise them so that they can do more? These are the kinds of questions. In that primary health care per capita expenditure, this is district health service expenditure, the fear is that we are now starting to spend less per capita in this space. The population's growing. So although you see the lines, the trend lines of rand allocated into the district health space increasing, it's not keeping up with population growth. And so we are seeing a per capita spend that is decreasing. Let's look at hospitals for a moment. So what I'm trying to show is inequity is everywhere. So besides the inequity between the public and the private sector, and in the private sector, the access for someone on a hospital plan compared to someone on a comprehensive plan. Get into the public sector. If you live in the Free State, you've got a better chance of getting a hospital bed than you have in Mpumalanga. Much better chance. Look at those figures. It's almost double. In fact, it's over double the number of hospital beds available in the Free State compared with Mpumalanga. These are the result of long spatial planning within our country that date way back to before 1994, in fact, back into the 70s. If you drill down even further and you look at bed availability per district, and you'll see where I'm going. You're drilling further and further down to show inequity is everywhere. What that means is that we as the health authorities and as the professional providers of services are making our patients work to access health services. In some parts of the country, they really have to work hard to move somewhere else to go and get that health care. And do we pay for their transport? Do we make it easy for them? No, we don't. We don't even help them to access beds in the private sector where they may be nearer to where they live. The inequity across these districts of physically. Now, not everybody follows a district boundary, as you know. If you live in Gauteng, you know that almost 1 million people move in and out of this province daily from Mpumalanga, Limpopo, and Northwest, and a little bit less from the Free State. So a lot of movement around here. But we have fiscal federalism, and we plan our services based on these population statistics. So if you look in the primary healthcare space, it's a little bit more equitable, and these figures may not be truly representative because Gauteng has quite a lot of services that are delivered not by the DHS of the province, but from the municipal services. But you still see these inequities in access in money that is allocated. One would expect Northern Cape to have the greatest spending because they have to drive 1,000 kilometers to go and find 6 sheep shearers somewhere in Namakwaland. If you go down into the districts, same problem. We have districts with very little spending compared with others. So the inequity in the spend between districts. Now, I could also show you the maps. All of this data comes from the District Health Barometer, of the DHIS or the District Health Systems data. It's all in the public domain, and you can look at it yourself. But the inequity is huge. It's 3 times greater to the best resource district compared with the worst resource district. So what are we doing about getting this equity sorted out? The summary of what I'm trying to say in this piece of the talk is that we need to fix these inequities in the public and the private sector. Until we say we need more money, and I'm well quoted in the media, and others with me are quoted in the media at laughing at the 1.3 trillion and the 800 billions and the thumbsuck figures. It's nowhere near that kind of money that's needed to run a decent health service in this country. You just got to spend it properly. 8.5% of GDP, which was 543 billion in 2021-22. It's now close to 580 billion this year. Is a lot of money. What are we doing with it? If you add the donors to it, okay, well, we used to add donors to it. Now we don't add quite as many donors to it. There's a lot of money in the system that is not necessarily giving us value. We duplicate so much. 9 different provincial departments, each do their own digital systems, their own way of running services, their own way of planning their health facilities, their own way of building, their own way of purchasing goods. The only thing that we centralize is the procurement of the pharmaceuticals. The remaining health products, medical devices and diagnostics, are all purchased by province. Small pools, small numbers, difficult to get good value for money on those kinds of prices. Then, of course, there's the military health services, correctional health services, and a whole range of other things. Plus 71 medical schemes who are buying, and then the individual is at a complete disadvantage trying to buy on their own. And they don't know they can negotiate prices and they can go and get prices better elsewhere. All of this duplication just increases administrative costs massively. The inequity is so obvious. The more, I could put up another 40 slides that will give you even greater worry about the inequity of access to services and resources. We're going to come to specialists, and you'll hear some of those figures as well. It's concentrated in the private sector. There's intra- and inter-provincial inequity, massive quality disharmony. Even within the public sector, massive quality disharmony from one facility to another, one district to another, one province to another. And of course, between public and private, there's a quality disharmony. But don't for a minute believe that you get better quality outcomes just because you go to the private sector. There's ample evidence. I was talking to someone the other day who was telling me about some of the horror stories of what's reported, because we talked to the CMS and we talked to members of boards and so on, of some of the inequity and the bad care that happens even in the private sector. So our systems are poorly coordinated. So if we had all these little disjointed bits, but we had a way to integrate them, and we had one way of having a portable health record. I tried to count the other day how many different health records I've got in South Africa. And I didn't grow up in South Africa. I was born here, but I grew up in Zimbabwe. So just since I've been here, I gave up at 44. 44 different places. Different hospitals, I have lived in 5 provinces, so you can understand why. But, you know, if you move around and you do different jobs and you work in different, you've got records, dental records, medical records, physiotherapists, surgical procedures, all over the place. So when I have to fill in every time I go to a new place, it takes you half an hour, and then you're on the first page, another hour to fill in all your procedures and stuff you've had. We don't have integrated records. So what's NHI all about? I want to clarify the 2 words equity and equality, because we tend to use them interchangeably, but in the NHI and in the legislation and in the global health space, we talk about equity. Equality is when you and I get the same care. But clearly I'm an old male, and I'm not a young female, so I don't want the same care as my daughters or my grandchildren. What I want is equitable access. So when I'm healthy, I need less. When I'm unhealthy, I need more. But I need the healthcare when I need the healthcare. That's the point of equity. It's fair access when I need the healthcare. So when we move into national health insurance, it's based on universal health coverage. The person who tells you it's universal health care has been listening to the Americans and the private sector. There's no definition for that. The WHO is implementing a United Nations Assembly agreement that our president and our country is a signatory to, that we will strive for universal health coverage. Simply put, and these things are never simple, every person, not every adult, every male, every child, every illegal, every legal, every person gets the quality health care that they need. I don't need health care today, but tomorrow I might need a lot. When they need it, when they need it, where they need it. So I don't need that inequity of access. If I need the healthcare to be within 20 k's or 5 k's or whatever of where I live, that's what we've got to strive for. And the main issue of universal health coverage in this country's NHI is without incurring financial hardship. Now, many people on medical aids incur financial hardship. 3 weeks in ICU when you were on a hospital package, and they were busy sticking things in you and pipes in your throat and doing all kinds of procedures to you, you will rapidly run out of your cover. And then you're on your own. You either get transferred to the public health service, or you sell your house or your car, or your neighbors collect the money for you. So it's not just poor people who get into financial hardships trying to access healthcare. So that is our mantra, universal health coverage. That's what we're striving for. So our NHI is different from every other NHI or national system in the world because we have several very unique characteristics. The most obvious of them is that our Gini coefficient is off the wall. For those of you who are not familiar with Gini coefficients, they're a measure of inequity. And we measure inequity in income and inequity in wealth. So in our country, inequity in income and wealth is sitting at about 0.63. It's an index and it's got various bits and pieces. The most equitable countries in the world are sitting around 2. The next most inequitable country in the world is sitting at 5.7, 5.8. And there are a few of them competing for it. Our neighbor, Namibia, is competing for it, and so is Brazil. But ours sitting at 0.63, and it's getting worse, not getting better. That's a mirror of what happens in society. But what are we doing about it as health professionals? So we need to find a way to take this enormous amount of money that we are spending and get bigger value for that money. And that's what the NHI tries to do. Now, some people seem to think that the NHI Act replaces everything. It doesn't. It amends only 2 clauses in the National Health Act, substantially. Section 25, and it adds a Section 31A. So what it does is it aims to pool the resources. So instead of having 9 different provinces and national and the correctional services and the road accident fund and the compensation fund and 71 different medical schemes, each with a separate pool in 311 different sub-pools, it says no. We all get the common set of benefits that the fund will pay for. It doesn't say you can't have other things. It just says what the fund at any point in time can afford to pay for. We're all entitled to that same set paid for by the fund. So it's pooling, one fund. Then it says the fund must purchase the healthcare. So it's like you personally purchasing or your medical aid purchasing or the province purchasing for you. What it does is it says the fund must do that purchasing. I can already see the complexities here. The fund must purchase the benefits that the fund is covering, not everything. And we'll talk about, but if I have time, I'll talk a little bit about where we get the money. The fund must contract directly with the service providers, so no middlemen all over the place. And that includes in the province, the public provider. So the fund will contract with public and private providers, and it will purchase from that hospital or that clinic. So in the public sector, the money will actually flow to the provincial administration, but it will go with the cost center code or the revenue code of the facility that delivered the services. That's the way that the act is worded. So what I'm trying to show is that all of these imbalances and differences, they need to be addressed as a whole. You can't just fiddle with one piece of the system and think that we're going to solve all the problems. Fix the infrastructure, you're going to fix all the problems. You're not. Fix the employment of doctors, you fixed all the problems. You're not. You will band-aid it for now, but you're not going to solve the systemic problem. So we are aiming for this purchaser-provider split. When will it be implemented? Well, the court papers say it will never be implemented because we're going to keep you busy in court until Crisp is 90, which is not that far off. But the intention is that this year and up to the end of next year, we get the administrative system in place. And then we have 3 years from 2026 to 2028 to get the purchasing mechanisms in place. And then it'll take another 10, 15, 20 years to systematically make sure that all the nuts and bolts are in place. And we were recently in the UK on their 73rd anniversary of the NHS, and they said to us, don't panic, it goes up and down like this, and it will do forever. We work closely with the Japanese. They said, we took 36 years to get where we are. Why are you phased? Some of the newer ones, like Indonesia, have been working at it for, I think they're in their 14th year now. We met them when they were in their 12th year, and they said, hey, we're just starting to get going. These things take a long time to implement. So I want to turn attention now to, in all of this reform and all what we are doing, I've obviously been critical that we are spending a lot of money and not getting value for money. Part of it is the way we look at ourselves and at those around us as other health professionals. So we got 29 colleges now. There are 27 registrable specialties in the HPCSA, but we have 29 colleges. 2 of the colleges are apparently not registrable specialties, but be that as it may. There are about 30,000 people on the database, if I'm correct. Dr. Buch can correct me, Prof Buch can correct me. Somewhere around 30,000. And if you go down and you look at who are the fellows and who are the associates or the specialists as opposed to the diplomats and the certificate holders, it's way less. It's closer to 15,000. But it's still a lot of people. The problem is, even at HPCSA, we don't know where these people are. We don't know if some of these college colleagues of ours are working in other countries and remain members of our college and remain on our HPCSA. So we are systematically working, and I'm going to give kudos to HPCA, who's working quite hard to make sure that we understand better who's working where and to make sure we know which people are actually registered as specialists to do what. So let's look a little bit, in the little bit of time we've got available, what does a clinical medical specialist do? Well, I would still argue, even though I'm critical that we're spending too much on specialists in the private sector, I heard in some of the previous discussions, we need more anesthetists, we need more this, we need more that. Well, when 80% of the anesthetists are working in the private sector, you feel like you need more. But how many diplomats are we training? Are we supervising? Are we overseeing to do relatively uncomplicated anesthesia? I'm talking to someone who in my first 5 years in practice did well over 2,000 anesthetics. Luckily, never with a complication, because I had this little guardian angel looking after me. So where do we get the value? Where do we draw the line? Some countries have nurse anesthetists, but we want everybody to be anesthetized by an anesthetist. So no wonder our surgeons battle to find anesthetists to help them. We have surgeons who are doing procedures that may probably be done by well-trained, experienced medical officers. Many of us used to do that. The older doctors amongst us know exactly what we're talking about. So maybe we've got to relook at this specialist. The specialists play a vital role. They're the people we go to. How many times did I sit on the phone pleading with a specialist in Petersburg when I was sitting in the Lowveld in first Limpopo and then Shilabana Hospital? Help me, patient's bleeding. I don't know what to do with this patient. So that we rely on our specialists to help us to understand specific diseases, conditions, and to help us with expert diagnosis and treatment. But we also rely on our specialists, if we can get everybody to work in harmony, in the overall health system. Because specialist care is an undeniable need. And we have many different kinds of specialists doing different kinds of things. I would argue we need to focus more attention on our mental health care specialists at this stage of our lives. We need more infectious diseases specialists still, because we haven't got out of the transition. We definitely need people who are dealing with endocrinology and the diseases of lifestyle, where there are many of the patients who have those conditions have complex conditions. So there's no question that we need specialists. There are three big areas that I just want to touch on briefly. The one is this expertise and knowledge. We believe, all of us as practitioners in the health system, nurses, GPs, and ourselves, that once you're a specialist, you've got in-depth knowledge. I certainly believe I've got more knowledge than most people in public health medicine. It would be shocking if I didn't. Because you keep studying, you keep understanding what you are doing. So I don't want to pretend to be a surgeon. I want a surgeon who has got that in-depth knowledge and who are able to be at that cutting edge and looking at better and smarter ways of doing things. Technology is changing all the time. We expect that our specialists will be interacting with that change in technology, advanced diagnostics. I can't read an MRI scan. There was no MRI scan in the whole of Limpopo long after I left. In fact, there might be one now. Is there? Probably do have. Yes, Shoshana, I see you nodding. I'm happy. There were only 200 doctors in the province when I was the HOD in that province. So things have improved. The second area is in the treatment and management of patients. Common things occur commonly. First thing that I was taught as an undergraduate student, look for the differential where the percentages are the highest in the common conditions. But for those few who have got complex conditions, complex treatment requirements, who don't respond, more antimicrobial resistance, difficult and recalcitrant responses to the drugs that we give them, who don't respond to the surgical procedures you do, who get complications. Everybody has these complex cases. So there's no denying that there's a massive role for specialists, particularly the clinical specialists, but even I'm going to argue for us. So the contribution to the health system is the most neglected, especially where you've got a massive private sector, where the system is designed to almost encourage people to work in silos and in isolation. The first thing is, specialists are at the apex of the referral chain. You heard the minister last night. This that everybody can just pitch up with their scabies and their ringworms and whatever to a dermatologist or a pediatrician. And 54, did he say? obstetricians and gynecologists in one hospital, more than 3 provinces put together. There are women out there who need specialist care. And they have to rely on the few medical officers to look after them because people are seeing patients that don't necessarily need their specialist care. They need care, but they don't necessarily need specialist care. So the first thing is that the specialist is at the apex of the referral network and needs to treat the patient while the specialist is needed, and then release them back to the primary healthcare system. And the primary practitioners need to have the discipline to send them back when they need to go back for checkups. Cardiac patients don't need to be supervised by a specialist at every visit, but they do need to be supervised. But then they do need to go back to the specialist for proper metrics and proper follow-ups. Education and training. Well, we should all be teaching and training, all of us. Every GP should be teaching, every doctor should be teaching. And if you're going to teach, that means you need to be learning. You need to be reading. But we rely on our specialists to teach and train the next set of specialists who will be at the apex of the system and looking after the complex environments. So we are desperately concerned that we don't have enough registrars in the system. It's a problem, and it's a problem because the way the budgets are allocated, they're allocated to a province. But we train specialists for the country, not for the province. So if a province runs into financial trouble, their need to divert money to other parts of the health system impacts negatively on the ability to teach and train the next lot of people who are coming through. And the minister spoke about RWAPs, people who go off and work during the time. I've got a friend who works here as a purely private plastic surgeon in Pretoria. We were medical officers together back in the day. And he said to me, hey, we got one of your professors been bragging here in our change rooms that in 6 months he hasn't even been in the hospital. I said to him, give me the name. You can't do half a whistle blow. You must blow the whistle. We need to investigate this person. It's disgusting. The third one is research and innovation. That's preaching to the converted. Everybody needs to be looking for smarter, better ways of doing things, preferably cheaper ways of doing things as well, getting to more people with our skills as quickly as we possibly can. And you won't do that without research and innovation. And these days, because money is always in short supply, what we are looking for is evidence-based. You won't do that if you don't have proper research taking place. And I must say, the quality of some of the biostats that I see of things I read, particularly in the court papers, is shocking. Multidisciplinary teams. So if a woman has a breast cancer in the public sector, you can expect that the surgeon, the oncologist, the plastic surgeon, maybe mental health practitioners and others will be involved in the care of that patient. But I have examples of people who just see a surgeon in the private sector and they must go and find their own other professional. So that failure to work in a multidisciplinary team is a design problem that we have created for ourselves. We have patients with spine injuries and spine degenerative disorders who will go to a neurologist, and the neurologist doesn't consult an orthopedic surgeon or a biokineticist or whatever. We can't work like that. We need to work in a way that we complement one another's skills. And that includes the primary practitioner, the GP. And then, of course, there's public health. We don't own public health because we're public health medicine specialists. Hopefully, we train people to be specialists in the areas, and I'll show you what we train them in. But everybody has a role to play in public health, in making sure that we stretch the rand further, that we get more for our spending, and so forth. So integrating into public health initiatives is everybody's role. And then I know that we get hammered for this, that we doctors think we're smart and we always think we've got to be the leader of the team. But in the clinical space and in clinical governance, that is our role. You have more training, you have more skills. So as a specialist must play a leadership role in the clinical governance. but not necessarily in the finances of the hospital and in the human resources and in everything else. There are people who are employed to do those jobs, and somehow we have to find that way to work together. So the essence of what I'm saying about specialists generally is that the role is crucial and that we can't do without specialists in the system. But, you knew there was a but slide coming. Is specialist care always appropriate? And the answer is no. We need to improve the way that we provide healthcare, and so therefore we do need specialists playing that role. And there are good clinical arguments for specialization which are listed there, and I'm watching my time and I've got 2 or 3 more slides to go. So we know that procedures have become more complex and you need people who practice with those complex procedures and diagnostics and so forth frequently, otherwise they don't get competent. So there's no question that there are good reasons for specialization. But I think there was a quote from Mark Britnell in an earlier speech, or maybe the minister's speech last night. He writes a lot about human resources. And there's an argument that if we leave specialists unfettered, us unfettered and unharnessed, that we don't work together with the generalists, we will not necessarily improve healthcare. All we will do is make debates about how we're wasting the resources, we get into turf wars, and you see it between specialties too. Pulmonologists will argue with cardiologists who should be doing this procedure. Radiologists will argue with pulmonologists, I should be doing this, and so on, instead of just working together to do it. So we need better teamwork. We need to see the system as a whole. So each person has got a set of particular skills. And even within specialties, people have things that they're really good at, they really like, they really do well. That's good. But we need to see the patient as a whole, we need to see the system as a whole, and we need better teamwork. Never been more important because there's less and less money. We need to work far more closely together to serve the patient. We've got to keep focusing on the patient. And in the public health sphere, we don't talk about patients as much as we talk about users of the health system. Because many of our patients aren't sick, so they're not really patients. They're people that we are trying to prevent from being patients. Specialization is not always appropriate for patient care. And I've given examples of that. We need to identify when we are inappropriately referring to the specialist, where we could be sending other patients with other complex conditions to the specialist. So we have examples of this. In South Africa, we have these things called district clinical specialist teams. They haven't succeeded everywhere, but in every one of the 52 districts, there is some vestige of a district clinical specialist team. The challenge in the initial model was that they were brought into an office to provide clinical governance across the system. Well, specialists don't function well. Clinical specialists don't function in an office. They need to be in care in a hospital. But they need to be working as the team who are providing the clinical governance, the training, identifying who needs to get a diploma in anesthetics. How do we get increased skills so that the medical officers can do a cesarean section or can do a sterilization or can do whatever procedures? Because they can't get to everything. So these district clinical specialist teams, we really need to relook at them and make them more effective. They had 7 people, 7 different sets of skills in them, and their roles included clinical training and monitoring, district level organizational activities, how to get cardiology working, how to get referrals working for the antenatal care when you picked up problems and get the patients into a care, more intensive care program, etc., etc. Collaboration, communicating and reporting with the managers of the facilities, ensuring that we implement all 4 tiers of the clinical governance framework that the department promotes, and strengthening the management systems by pointing out where there are gaps. And I've given the reference of where you can find reports and details about it. That brings me finally to us, public health medicine specialists. And I see a lot of other clinical specialists here, so I'm talking to the College of Public Health Medicine, but I'm also talking to the rest of you to understand what is it that we are trained to do. Well, the difference is that our training is to focus on the population. So back to the day when Eric told me, hey, you need to do public health medicine, which is called community health in those days. I said, what's that? said, well, you can operate on these patients who had polio. So I was in the epicenter of the polio epidemic that had occurred in 1982. So there were lots and lots of patients with post-polio deformities. And because I wanted to be an orthopedic surgeon, this was just my bread and butter. And then it was brought to my attention, well, I worked in the pediatric ward, so I saw neonatal tetanus. At least one new baby, this big, with neonatal tetanus every week. I don't know how many of you have treated neonatal tetanus, but it's soul-destroying. Those that don't die definitely have mental illness after that, brain damage after that. The fitting and the breaking of bones, those little rubbery bones break. It's soul-destroying. And John Hanson, who many of you will remember, who was a pediatric professor at Wits University, popped in one day, shortly around about the time that Eric was harassing me, and said, why don't you just immunize the mothers? I wrote it down. Why don't you, I was 20-something years old, like, well, you know, who am I? Just, like it's a walk in the park. Immunize. Oh, I wasn't paying attention to immunization when I was a student, so I wasn't quite up to speed on that bit. The mothers. Who's a mother? Where am I going to find these mothers at 16 weeks and again at 24 weeks to give them TED Talks? And so began a journey of identifying how to set up a vaccination program, what is a cold chain, how the pharmaceuticals work, and so forth and so forth. So then I ended up running the COVID vaccination program, which was a whole nother ballgame. So we focus in the way we look at things, at the whole population rather than at the one. You don't see rewards, that's the problem. If you operate on a child that needs a suture slide and you do the suture slide and tomorrow they're in a spica and standing or lying flat prone on their tummies, they haven't been like that for months. It's hugely rewarding immediately. But if you get a polio vaccination program going, you don't even know if you did anything, because now you just don't see polio anymore. So it's not easy to have a population-orientated approach, but that's our primary job. We do get involved in clinical services, but to the extent that those clinical services have population impact. So mostly the infectious diseases in the past, but more and more in the prevention of hypertension, the prevention of diabetes, etc., etc. And of course, a lot in child health programs. So what do we get taught? I can't really remember because it was in the 80s when I started, but these are more or less the things that, I believe you teach these things now. Now, I know you do. So epidemiology, the study of the behavior of diseases. Biostatistics, so that you can actually interpret that data that you get out, whether it is routine data, whether it is research data. Public health and society, being a responsible citizen and being a responsible practitioner. Quantitative research methods. This is really more and more important because we see a lot of stuff that's being generated, AI and otherwise, that does not hold up. Wrong sample sizes, incorrect parameters, and so forth. Health systems. So that's my bread and butter. How do the bits and pieces fit together or not fit together to make them efficient? What are the building blocks of those health systems? Health policy and planning, including the law. How does the law, international law, domestic law, regulations, bylaws, how does the law and the policy that leads to those laws and the planning that goes behind them help us to get more efficient use of resources? That brings us to economics. There will never be enough for us to purchase everything we want to purchase. But understanding the macro and the microeconomics, the environment within which we are trying to operate and build a health system is part of what we are trained. More and more important now, evidence-based medicine. It's really easy, it rolls off the tongue nicely. But do we understand the evidence? Do we understand what health technology assessment is about? Its strengths, its weaknesses, and its failures. And then the epidemiology of communicable and well, I sort of mentioned epidemiology, but specifically looking at those two sets of really prevalent diseases. Obviously, in our country, they might be different from another one. So, as we seek collectively to create a more responsive health system, which will intervene early with preventive care, and as funds become more constrained, it's the skills of public health medicine specialists, together with our clinical colleagues, that becomes critical in the evidence-based decision-making, the hard economic decisions and the formulations of the agile, targeted policies that we need to care for everybody. So you heard earlier in the introduction that Saendra gave, that we have worked hard to bring specialists into our space. Since the NHI branch and ultimately the NHI fund will be about reforming the way we do things, the skills that we teach in public health medicine become really important. They are not the only skills we need. And we do have family medicine specialists now and others who are part of our team. So I would also just throw down the gauntlet, as the minister did last night, and say, I would even warrant that if we made it compulsory to have some form of public health qualification before you can manage a health resource, a health system, hospitals, big health centers, and so on, I think that we would run a far more efficient and effective health system. So I want to end by reminding us what we pledge every time we go to an admission ceremony. There are principles in the Colleges of Medicine pledge. We hold, as specialists, a very, very special place in our professions and in society. And sometimes it's easy to just get sucked into the day-to-day grind and not pay attention to this. They deal with social justice and health equity, not just for those of us who work in the public sector, for everybody. It focuses heavily on patient care. It focuses heavily on professional integrity. We are it. We are the ones who have to talk and face the patient. It relies on us to engage in continuous learning and to teach and mentor the people around us. And then it implores that we should adhere to the conduct rules. This is my last slide, where you can read it for yourself, and you will see that those principles, which I have said we should hold dear to ourselves, we should have this up on our walls and remind ourselves on a regular basis why we come to work every morning. Count the number of times it talks about patient. Count the number of times it talks about bank balance. Count the number of times it talks about me versus us. Then we'll run a better health service. I thank you.
Thanks, Nicholas, so much for that very thought-provoking lecture and asking the hard questions. I know we're running behind schedule and the workshops need to reconvene, so I'm going to ask Professor Tracy Naledi to quickly respond on behalf of the College of Public Health Medicine.
Thank you very much, Professor Moodley, and thank you very much, Professor Crisp. When my president, Professor Moodley, asked me to be a respondent for Professor Crisp, I kind of felt like I'm being asked to have a mediocre performance after Beyonce. So, and I ain't no Beyonce. So thank you very much, Nicholas. That was a really thought-provoking lecture. And listening to your talk, I'm struck by two themes that I think run through South Africa's health story. And one is of deep inequity, as you've alluded to, and another one is of enormous opportunity. We spend, as you've said, 8.5% of GDP on health, more than many countries that are similar to us in terms of level of income, yet we deliver outcomes that do not match that. On one side, the small minority enjoy world-class specialist care. On the other, the vast majority rely on under-resourced public service, as you've said. And these numbers translate into whether a child with asthma is stabilized at a clinic or ends up in an ICU bed that actually does not exist. And I think this is where the opportunity is with the NHI, where we can really just stop tinkering around the edges, but really do proper health systems transformation. I think we are being asked to reshape health as a public good, not a commodity, and as a matter of solidarity and not privilege. That is why your focus on the role of specialists in particular was so important, and I want to take away 3 themes that I think have resonated through your talk and have also come up through the conversations as we've had over the last 2 days. The first is seeing a specialist as a system steward, that their bedside expertise is absolutely invaluable, but their greatest impact may be in multiplying the capacity of the system. The specialists have been instrumental in teaching and research and in developing the next generation of clinicians and innovating for improved care. And the example that you shared with us of the district clinical specialist teams really give us an example of what more we can do beyond just individual care, where we can embed specialists within the health system itself, doing training, mentoring, strengthening governance. We can really have improved health outcomes. As we know, we've had some evidence of improved maternal and child health outcomes because of the district clinical specialist teams. So it's absolutely possible for specialists to take on this new role where it's more than just providing services at tertiary hospitals, more than just teaching at teaching institutions, and to really influence everyday quality of care at primary, district, and regional level. The second is reimagining what it means to be a specialist. As you've said, too often we equate specialization with high-tech, hospital-based care, etc. But the true value that we can leverage is not really whether a cardiologist can unblock an artery in Cape Town, but whether they can provide capacity for a nurse in Limpopo to be able to treat somebody with hypertension. A pediatrician can build skills to grow, to manage growth faltering, make sure that it's caught early, and we have less need for specialists. So specialists can really be an important bridge of excellence, not just isolated islands of excellence as we see now. Thirdly is the indispensable but sometimes overlooked role of public health medicine specialists, as you've said. And as we implement the NHI, the hardest questions that will arise will be which services to purchase, how to prioritize limited funds, how to prevent late-stage costs with earlier intervention. These require, as you've rightly said, skills that we as public health specialists have: epidemiology, health economics, health systems design. And as public health specialists, we are trained in these areas, and we agree with you as a college that we should be bold enough to say that in management and leadership positions, we do need people with this expertise. And as a college, we are working on a postgraduate diploma in healthcare management that we hope will contribute to that capacity. In my view, however, we do need to confront some challenges that sit very uneasily in the heart of our health system. The one is the workforce paradox. We continue to train most of our specialists for the urban hospital-based practice, while, as you alluded to, the greatest need is in rural district services, and actually what we need are health system stewards. As the colleges of medicine, should we not be redesigning what we teach, how we train, and where we actually distribute these specialists and the functions that we ask of them? You alluded to in particular around leadership expertise, which I don't think we do enough in terms of training our specialists, and this new role of being a health system steward. The other is a social contract. I think there's no doubt that specialists hold high trust and influence because health is ultimately a matter of human rights. But the Pholela tradition reminds us that rights are not abstract. They are lived through equity, dignity, and accountability. Those values are eroded not only by poor policy choices, mismanagement, or corruption, but they are also eroded by our failure to hold ourselves and each other accountable. Think of bullying of junior doctors and others. Think of mismanagement or abuse of RWAPs. All of these things really undermine dignity and corrode the culture of care. Silence, whether outward or inward, can be complicity. Perhaps the new professional contract, Truth through the Spirit of Pholela, requires that specialists not only care for individual patients, but also uphold standards within our own profession and stand as visible advocates for integrity, sound policy, justice in health. Colleagues, this is not about setting specialists against generalists or public against private. It's really about how we re-engineer relationships so that patient need, not professional silo, drives care, and so that justice, equity, and dignity remain the compass points of our health system. Allow me to close with this challenge to all of us. NHI cannot succeed as a project of government alone. It must become a project of the profession and indeed of the nation. The CMSA pledge that you reminded us of, Professor Crisp, really brings to bear that our duty is to social justice and health equity. If we take that seriously, specialists can be champions of reform, leaders who restore trust, strengthen solidarity, and multiply excellence across the system. We are living through a daunting but extraordinary moment. If we grasp it with courage, specialists will not only save lives, they will help reshape the destiny of our health system for generations to come. Thank you very much.
Thanks so much, Tracy, for that. So I think we are going to close. So let me end with a few thank yous, obviously to Nicholas for accepting the Pholela Lectureship and that great lecture. To my membership subcommittee led by Dr. Atya Mosum, who were responsible for the nomination process that ultimately led to the awardee. CMSA Education Office, Evelyn Chetty, for the support in terms of the admin processes. In terms of the logistical arrangements for the Pholela lecture, I think a big thank you to the CMSA team led by Helene van Rooyen for all of the support. And I think that is about it. I'm just going to ask Tracy to hand over the gift to Nicholas. I will hand over his Pholela lecture certificate, and then the lecture will be closed. Thank you, everyone.